In this Florida Live educational video on pancreatic fluid collections, we will examine the relevance and role of plastic stents in the new era of lumen-apposing metal stents. The Orlando Protocol offers a structured algorithm for the management of pancreatic fluid collections using mostly LAMs and plastic stents in specific circumstances that yields overall treatment success in 95% of patients. Plastic stents are required for drainage of pseudocysts in the setting of an obstructed pancreatic duct that cannot be endoscopically treated, as the stents must indwell indefinitely. A patient with chronic calcific pancreatitis and symptomatic pseudocyst underwent an EUS examination. The echo endoscope was passed into the second portion of the duodenum, where a stone was visualized within the main pancreatic duct in the region of the neck of the pancreas. A pancreatic pseudocyst was also seen downstream to the stone. An ELCP was performed in order to insert a pancreatic stent. However, the stone was causing a complete obstruction of the main pancreatic duct, and the guide wire was unable to be inserted past the pancreatic duct stone. Therefore, EUS-guided drainage of the pancreatic pseudocyst was performed using two 7 French 4 cm double pigtail stents. These transmural stents will remain in situ indefinitely to minimize the risk of pseudocyst recurrence in the setting of complete pancreatic duct obstruction. Another common setting for use of plastic stents is for the drainage of necrotic collections in the setting of disconnected pancreatic duct. Disconnected pancreatic duct syndrome is a condition where the upstream gland is disconnected by the necrotic process, and the pancreatic duct terminates into a pancreatic cavity with necrosis and fluid collection. As the upstream gland is not in communication with a major papilla, patients with DPDS have a high rate of pancreatic fluid collection recurrence in the long term. Therefore, once the necrotic collection resolves, the lumen-apposing metal stent must be replaced for plastic stents. Alternatively, the patient can be treated at index intervention using plastic stents, which can be left in situ indefinitely. In this video, we'll be demonstrating the management of disconnected pancreatic duct syndrome in a patient with necrotizing pancreatitis. This 54-year-old female with history of acute necrotizing pancreatitis had undergone EUS-guided drainage of a ward of necrosis by the transduodenal route using a lumen-apposing metal stent. CT scan performed 3 weeks after stent insertion showed a complete resolution of the ward of necrosis, and therefore the lumen-apposing metal stent was removed. On EUS examination, viable pancreatic parenchyma was visualized within the head and body of the pancreas. The collapsed ward of necrosis cavity was visualized in the area of the neck of the pancreas, with the main pancreatic duct terminating into this area of collapsed cavity. These features were pathognomonic for disconnected pancreatic duct syndrome. Due to the presence of disconnected pancreatic duct syndrome, a decision was made to place plastic stents through the transmural tract and into the collapsed ward of necrosis cavity in order to minimize the risk of ward of necrosis recurrence. A guide wire was inserted through the transmural tract and into the collapsed ward of necrosis cavity. Then, a double pigtail plastic stent was inserted into the ward of necrosis cavity and through the transmural tract over the guide wire. On injection of the main pancreatic duct under EUS guidance within the area of the body of the pancreas, contrast was seen leaking from the main pancreatic duct and into the area of the ward of necrosis cavity, consistent with a disconnected pancreatic duct syndrome. In a recent meta-analysis of randomized trials, we found no difference in clinical outcomes between LAMs and plastic stents for drainage of necrotic collections. Another uncommon situation where plastic stents are indispensable is in the treatment of collections at atypical locations that cannot be accessed using LAMS. The 63-year-old patient who underwent distal pancreatectomy and splenectomy for pancreatic cancer developed sepsis from 2 infected collections, one in the pancreatic resection margin abutting the proximal stomach, and another in the splenic bed, which was subdiaphragmatic. The collection at the anastomotic site was drained using LAMS from the proximal stomach. However, the second collection in the splenic bed could not be drained using LAMS as the catheter was too stiff to exit the instrument channel in a semi-retroflexed position. As the collection could not be accessed by interventional radiology for percutaneous drain placement, EUS-guided drainage of the collection was performed using plastic stent. First, the collection was accessed using a 19-gauge FNA needle. After coiling a 0.025-inch guide wire within the collection, the tract was dilated using a 4mm hurricane balloon. Please note the acute angle at which the collection is being accessed. A double pigtail plastic stent was then deployed into the collection in the subdiaphragmatic region, and it could be visualized on endoscopic view on retroflexion only. We hope that this Florida Live educational video has impressed upon endoscopists the need to be proficient with plastic stent placement under EUS guidance. This technique will be demonstrated at Florida Live by Professors Takao Itoi and Pierre Dupre. Please register and attend Florida Live EUS from August 17th to 19th, 2023 in Orlando, where the Magic of Endoscopy begins. If you want to observe and learn evidence-based practices and know more about state-of-the-art EUS technologies, please attend Florida Live EUS from August 17th to 19th, 2023 in Orlando, Florida, where advanced interventions will be performed by internationally reputed faculty from around the world. Please join us at Florida Live, where the magic of endoscopy begins.